Welcome you all to the webinar. For those of you who don't know me, my name is Dr. Lauren Levine. I am the host and moderator for the webinar. Anytime Dr. Kosinski is speaking, we get a massive turnout, and that was no different this evening. We have close to 850 people who are registered. As always, I hope that everyone's staying healthy and safe out there. I commend you for being here, continuing your dental education. I'm only going to speak as usual for a couple of minutes, do a little bit of housekeeping. I want to make sure that Tim can speak for as long as he needs. And he wants to make sure we leave time at the end for questions. Most of you have been on the webinars in the past, so you kind of know the format. If it's been a while, this is your first time, our speaker will typically talk for 50 to 60 minutes, give or take. We don't have the ability to do verbal questions, obviously, with 850 people. But on your screen, you should have a GoToWebinar control panel. You can type in your questions as you think about them. We always leave time at the end. Our webinar, as usual, is being sponsored by GoldenDent. They're going to be offering some specials at the end. So that typically leaves about 15 to 20 minutes for questions at the end. Sometimes we get 3 questions. Sometimes we get 53 questions. I do my best to get to as many as possible. We do need to end pretty much in about 90 minutes. So if for some reason I don't get to your question, don't worry. I'm going to forward this all the questions along to GoldenDent, and they'll be able to follow up as well. So a couple of things. First off, you should receive an email sometime in the next day or two that has a link to download the recording of the webinar. I do record all these webinars. So if for some reason you don't make it to the end, if you have something else that's distracting you, don't worry about it. You're going to get the full audio and video. During the webinar, Dr. Kosinski is going to be showing some of the products and systems that he uses, which are exclusive to GoldenDent. I've had the pleasure of working with Kurt and Jackie and Jason over there for probably close to 10 years now. These webinars don't happen without their sponsorship. They're the ones that are bringing in the speakers. They help to develop the topics. They also will handle the CE. I get a lot of questions after the webinars about CE, so I'm going to try to mention it at least a couple times this evening. First off, you need to be logged in. If you just called into the webinar and didn't actually click a link, you're not registered because everyone has the same phone number. When you were sent a registration code, it has a unique link. And plus, it's a PowerPoint presentation. I mean, you can't really watch and learn anything if you're not watching the screen. So if all you did was phone in that you're not registered, please make sure you click that link to be in there. If you can see something on the screen, then that means you're in. But there's nothing you need to do. We track everything, when you logged in, when you logged out, how long you were here for. I send that along to GoldenDent. They will send out the CE forms. With 850 or so people registered, that can take a while. Sometimes it'll go out as early as, say, Friday. Usually it's closer to a week or so. Keep an eye on your inbox, on your spam folders. They do send it out. If you don't have something by, say, next Wednesday, by all means, reach out to me. I'll reach out to Kurt and Jason, and then they'll follow up with you. So with that out of the way, we, as I mentioned, anytime that Tim Kosinski is speaking is when we have our highest turnout, and that is true today as it is always. These are just amazing clinical topics, and we just get a great response from everybody. For those of you who don't know Tim, he's an affiliated adjunct clinical professor at the University of Detroit Mercy School of Dentistry. He's on the editorial board of Reality, which is the information source for aesthetic dentistry. He's a past editor of the Michigan Academy of General Dentistry. He's currently the editor of the AGD journals General Dentistry and AGD Impact. He was also named editor of Implants Today, which is the implant publication of Dentistry Today. Back a couple of years ago in 2023, he was presented with the ADA, AAA, DEJ's Distinguished Editor Award. He's past president of the Michigan Academy of General Dentistry. Like all of you, he's a DDS. He got his from the University of Detroit Mercy Dental School. He has a mastership in biochemistry from Wayne State University School of Medicine. He's a diplomat of the American Board of Oral Implantology and Implant Dentistry, the ICOI, and the American Society of Osseointegration. He's a fellow of the American Academy of Implant Dentistry, and he got his mastership in the Academy of General Dentistry. if you're in dentistry, you have to know who he is, unless you've been living under a rock or something. He's received many honors, including fellowship in the American and International College of Dentists, the Academy of Dentistry International. In 2017, he received the Academy of Dentistry's International Humanitarian Award in recognition of significant contributions to the enhancement of the quality of life and the human condition. He's a member of the OKU, the Pierre Fauchard Academy. He was University of Detroit Mercy School of Dentistry Alumni Association's Alumnus of the Year. In 2009, 2014, and 2020, he received the Academy of General Dentistry's Lifelong Learning and Service Recognition. If you're into implants, he's probably got you beat. He's placed over 19,000 dental implants. He's published around 250 articles. Like I said, if you're in dentistry, you have to know the name. His articles run the gamut from surgical and prosthetic phases of implant dentistry, and over 100 dental editorials. He was a contributor to textbooks, Principles and Practice of Implant Dentistry, and Dental Implantation and Technology. Tim, it's a lot, but you do a lot. We are so thrilled to have you here. Looking forward to the presentation, and take it away.
Lauren, you always make me giggle a little bit. I appreciate that.
That's the plan.
Well, welcome everybody. We do have a big turnout today, and hopefully we can spend an hour together and take a couple gems away that you can use in your practice tomorrow. Lauren, again, thank you for the introduction. For those of you who don't know me, I am a general dentist in Detroit area. I'm proud to say our Detroit Tigers are doing really well, and our Lions played pretty well. And today's topic is very, very important. Lauren, you mentioned that I place a lot of implants, and implant dentistry has obviously gone through a lot of advancements in my career, and it's really nice to be able to give back. But one of the most important things that we have to realize in implant dentistry is that we have to create a foundation for our dental implants. Dental implants are only successful when we have health of the patient, no uncontrolled healing issues, and obviously we have to have a viable bone to be able to have integration of our dental implants. So growing bone is a very, very important part of my practice, as is extractions. You know, we coined a term, I think Kurt and GoldenDent, we coined a term atraumatic extractions probably 15 years ago or so, and you know, early on we were a little bit criticized for that term. How can extractions be atraumatic? But minimally traumatic, if you want to use a better word. Tonight, in the short time we have together, what I want to demonstrate is a couple materials that I use, a membrane that I use, and how we can predictably grow bone. And I'd like to say I can show you how to grow bone 100% of the time. And that's a very bold statement from this guy in Detroit. But we're specifically going to discuss when we take a tooth out, we create a socket, and that socket has all the walls intact. We can call that a 4-wall defect, or even a 5-wall defect if you count the floor, or if the facial wall is missing. And those are two very common areas. We take a tooth out, maybe we'd like to place an implant or maintain the vertical and horizontal with the bone, or if we do happen to fracture the facial plate, how can we build that facial bone predictably? And so we're going to specifically direct our discussion to those topics. How many walls does your extraction site have, and how do you deal with it? Whether you have a facial wall missing or all the walls are intact. And so we're going to show you the grafting techniques that I use literally every day in my practice. And obviously suturing is a very important part of that. I know, Lauren, we've done suturing programs in the past, and those seem to be very, very popular. We won't spend a lot of time with it, but maybe in the future we can dig one of those up for our attendees. So let's move on. You know, we also have a place up in northern Michigan. This is beautiful Lake Michigan in the Twilight area. The website that you see on the bottom screen, drkosinski.com, is my education website, Lauren, and it is not an office website. It is simply has a lot of my published articles and a lot of video demonstrations of the things that I'm demonstrating today. So I think it is a good resource if you want to get a little bit more information, or, you know, I have a tendency to speak rather fast to cover the information. I think that would be a very good resource for our attendees tonight. So our objectives, what are we going to try to do today? We're going to try to learn, as I mentioned, some atraumatic or minimally traumatic extraction techniques that maintain bone. In today's environment, a bone is gold to us. And the more bone that we have to work with, the better our aesthetics and function will be over a long period of time. I've been placing implants for 40 years now. And I've seen a lot of transitions, and never in our history, this is a great time to be a dentist, because never in our history have we been able to provide such predictability to our patients. Protocols for most common socket types. We're going to talk specifically about extraction sites where all the walls are intact, and if a facial wall is missing, how we can predictably grow bone in those areas to prepare a site for dental implants. And we all understand that dental implants are probably the most financially rewarding thing we can do in dentistry today. And so learning these techniques is a very, very important part of your business practice. And we're going to talk about different the graft materials that I use. Now, obviously, there's a myriad of materials. There's a myriad of techniques that you can use to be successful. And I can only demonstrate what I use every day, that I've morphed into predictability, efficiency, and I'm able to provide a tremendous service to our patients at a fair cost. And we're going to talk about the materials that I use in specifics, which I think will be very helpful. We know, everybody here knows, that if we take teeth out, bone is going to be lost, okay? Bone is going to shrink down and in the lower jaw, up and in the upper jaw. And those are the two areas where most of us have concerns about dental implants. We're concerned about the position of the mandibular canal, and we're concerned about the position of the sinus area. We don't want to numb anybody, and we don't want to place an implant in an air cavity. We also know that in the maxillary posterior area, we have sinuses, and I'll tell my patients sinuses are air cavities that are given to lighten our skull and to warm the air. And we also know that our tooth roots act like a tent pole holding up a circus tent. And ask your patients, what happens to the circus tent if you remove the tent pole? I did that today to a patient and just put it in their terms, and they immediately said the circus tent will fall. And that's correct. So grafting is a very, very important part of our implant procedures in maintaining a viable bone. And in a very short amount of time, in a very short 3 to 4 months, we can objectively take a digital radiograph and determine bone turnover to determine if our site is, again, viable for our dental implant. Physiologically, our grafting material is going to integrate from the apical portion of the socket towards the crest. So we're going to get faster integration in the apical third than we will in the coronal 2/3. But our initial stability with any implant is in the apical 2 millimeters. So I routinely will extract a tooth, graft a site, maybe allow it to heal if I'm not doing an immediate implant, place my sutures. I like to see my patients in a week to remove the sutures. We'll talk about that in the program today. And I will see that patient back, depending on the size of the socket, in 3 to 4 months, scheduled with the idea that I'm going to place my dental implants, and allow that implant to, again, integrate over a period of time, an additional 3 or 4 months, depending on the position in the jaw. Height, width is going to decrease. We know our denture patients oftentimes will lose bone, and we will get a dehiscence of the mental canal, mental nerve, which can cause paresthesia, and the face will collapse. So another very important education verbiage for your patients is our dental implants can help minimize future bone loss over a period of time. And I think that's very, very important and easily understood by our patients. Without stimulation of the bone with teeth or with our dental implants, bone is going to continue to shrink over a period of time, which can result in long-term negative consequences for our patients. If we graft, and routinely, if I take a tooth out, I am going to graft. And now many of you will say, well, my patients don't want it. Well, it's not that they don't want it. Our job is to educate and instruct them on why it's important that we graft. The reason they probably don't want it is because of the cost involved. And if they don't have dental insurance coverage with the grafting, that's another negative factor that influences the psyche of our patients. So these next two slides are very important, maybe some of the most important slides in your communication in the entire program, and you may want to take a snapshot if you have your phone out. So if we graft at the time of extraction, we will help minimize bone loss. It'll help maintain soft tissue architecture, to some degree help prevent periodontal pathology, and we will routinely be provided an adequate site for dental implants in a very short 3 to 4 months, routinely. If we do not graft, then soft tissue is going to infiltrate the socket. Epithelium grows about 10 times faster than bone, and I already mentioned that in a socket site, we get integration, socket healing from the apex towards the crest. Epithelium goes from the crest towards the apex, and if the epithelium grows 10 times faster, it's going to be a race, and you're going to get shrinkage of bone. The literature says up to 30 to 60% bone loss in a short 3-year period. So this may result in a site where the patient may need a much more invasive surgical procedure to grow bone back, and a much more expensive surgical procedure to grow bone back. So educating your patients on why this is important is critical to getting patient acceptance. The issue that you have is some of our materials are very expensive, and you have to justify the material cost and your time involved because it is a business. So we're going to demonstrate two materials from GoldenDent that I think are very, very cost effective. The first is a synthetic material called Osteogen. It's a calcium apatite material in a bovine Achilles tendon matrix. It's made in a laboratory. I call it a synthetic material, and it consists of the same building blocks as natural bone. The other material from GoldenDent is an allograft material, which is human bone, mineralized cortical cancellous bone, and that has particulate size of 250 to 1,000 microns. Now, whenever we're using an allograft, and I will demonstrate this clearly, we must protect that allograft from invagination of epithelium. As I said, epithelium grows 10 times faster than bone. So we need a membrane that will remain intact at least 6 weeks to allow for bone turnover. Very, very important rule, and I will discuss it clinically in just a few moments. So it's important that we understand the process and what we're attempting to do. And I'm going to show you my basic rules to grow bone very, very predictably in your patients. So many of us, and you may be listening today because you've done a graft, you understand you have to put material in, but the graft fails. And why does that happen? Well, suturing is very, very important. You must maintain the surgical site. And if we don't suture correctly, it can result in failure. If we're using an allograft, we must passively place that membrane, long-acting membrane, a resorbable membrane, at least 2 millimeters beyond any defect that is present. That membrane must remain intact for at least 6 weeks. If it comes out before 6 weeks, then the case becomes unpredictable. So if any of you have done that, where you've done a graft, maybe you put a membrane, but it came out, you don't even realize that it came out before 6 weeks, and you've gone back, excited to place an implant, and found that the area is just mush. Very, very frustrating and not very cost effective for you or the patient. And if you maintain an infected area. Now, when we're taking a tooth out, we must clean out any granulation tissue. We curette, and GoldenDent has a great surgical kit that can be provided to you. You must use sharp instruments. We want to remove as much granulation as possible. Purple blood is bad, red blood is good. And if you're able to do that, we can predictably place a graft material, one of the two that I'm going to talk about in a few moments, and grow bone predictably. Now, if we do have any semblance of an infection, a fistula, I will not immediately place an implant in that socket. I will not immediately place an implant in the socket, but I will graft the site. And the analogy that I use is if you've ever had a hangnail, you can be miserable, unbelievable pain. You soak your foot, you clip the nail, 5 minutes later, your body doesn't even remember that you had an issue. And that's the same rationale when we have an infected tooth. If you remove the source of the infection, remove the granulation, we can get a good grafting result. The resorbable membrane I use resorbs in 3 to 4 months. It's purified intact collagen from porcine peritoneum. very easy to reposition, does not have sides to it, very easy to manipulate, and passively place it beyond any defect. The allograft material is cortical cancellous particulate, and it's osteoconductive, and we get rapid revascularization and structural integrity as long as we protect it from invagination of epithelium. And the techniques that we're going to demonstrate clinically and that are on drkosinski.com, I think will help you be very successful. The allograft material is a powder, like a crystalline powder, and we will wet it with sterile water or sterile saline. We never wet allograft with anesthetic. Anesthetic is pH of 2, and it will inhibit osteoclastic activity and may result in non-integration or non-bone turnover. Remember to tell your patients, regardless of which material we're using, we're not pouring concrete into a socket. Rather, this is a living physiologic reaction. That whatever we do is going to be turned over into natural bone in a period of time. And the GoldenDent particulate is very cost effective. I'm sure will have specials today if you talk to Kurt. And we get great bone turnover in a very short amount of time. As I said, 3 to 4 months, I predict. EpiGuide is a second membrane that's available. And it is a synthetic material. It's bioresorbable. It does have a side to it, and it will maintain its integrity for 20 weeks. It's resorbable, but I only need my membrane to remain intact for 6 weeks. So this is another alternative membrane material that you may want to use. As I mentioned, the Osteogen plug is my go-to. If I have a socket site with all walls intact, this is my go-to material. If I have a facial defect of 5 millimeters or less, this is my go-to material. If I have a facial defect, the facial wall extends beyond 5 millimeters, then I will use an allograft with a resorbable membrane that is placed at least 2 millimeters beyond the defect passively, and it has to remain intact for a minimum of 6 weeks. We'll show those clinically in a few minutes. And as I mentioned, it's calcium apatite in a bovine Achilles tendon matrix. They're little bullet-shaped. These are not collagen plugs. Collagen plugs are not grafting material. This is a true graft that I personally have been using probably for 15 years. And I can honestly say I probably open a package every single day, if not more, in my practice. We do not need a membrane with this material. And again, the physiologic reaction is the same regardless of the material. We will get osteoclastic activity, stimulation of osteoblasts. We will get bone turnover from the apex towards the crest in a very short 3 to 4 month period of time. The advantage of this material, it is very inexpensive. It's $30 or $40 for the graft, and you do not need a membrane as opposed to an allograft material, which may be $110 for a cc and another $110 for the membrane. So you can see the cost effectiveness of this material will allow you to provide this service to your patient at maybe a reduced fee, and it becomes not important if insurance doesn't cover it, because again, we're educating our patients on why socket preservation is so critical. And we just talked about that. So let's move on. So today, from now on, we're going to talk about 2 types of defect. What's referred to in the literature as a 5-wall defect, where all the walls are intact. We have a socket where the facial wall is present, or a 4-wall defect where the facial wall is missing. These are the sites that we will use these 2 materials, and I will show you techniques that will make you extremely successful. This is a young, beautiful person that presented to the office as a new patient, very apprehensive, very upset, fractured a tooth, decay, and we had to make a decision on how we were going to treat it. And you can make the decision that's right for you. Maybe some of you, maybe we could do a post and core, a crown, some crown lengthening. I want you to clearly look at the interseptal bone in this area, which is blunted to some degree, and there doesn't appear to be any interseptal bone on the distal aspect. To have interdental papilla, which is so important periodontally in our aesthetics, we must have interseptal bone. So maintaining interseptal bone is as important to me as anything that I do in my practice. I'm going to ask a rhetorical question. How would you remove this tooth in your practice today? Taking teeth out is tough. It's not an easy thing. So I'm assuming many of us would take a luxator or a periotome of some degree and see if we can luxate that tooth. Root canal treated teeth can be challenging to remove. If you don't have a purchase point, I'm assuming that some of us would take maybe a 557 surgical burr and try to get a purchase point on the mesial or distal aspect of the root so that we could try to luxate it out. Again, removing interseptal bone will result in loss of interdental papilla, which will compromise our aesthetics, final aesthetics. Our laboratories may need to compromise making the teeth wider. We've all seen that look, wider than normal, or we end up restoring the adjacent tooth, which the patient was adamant, did not want to touch, adamant, to try to improve the aesthetics with a veneer or something like that. So these are the physics forceps, and Kurt and I have been working together probably for 20 years. Kurt, I'm not sure, maybe longer. And it is a series of 4 instruments, for upper right, upper anterior, upper left, and lower universal. It consists of 2 components. The shovel-shaped beak is the working end of the instrument. This shovel-shaped beak will engage the lingual or palatal aspect of a root 1 to 3 millimeters subgingival. The bumper is placed as high up the vestibule as possible and is not the working end of the instrument. It is simply acting as a fulcrum or a center of rotation. And without any squeezing of the instrument, I wish they didn't call it a forceps, I can simply push on the lower part of this handle towards the patient's nose with constant pressure, and in a matter of seconds, literally maybe 30 seconds, the tooth will luxate following that arc of the rotation of this specially designed instrument, and it'll luxate this tooth up and out of the socket. Now, it's not intended to remove the tooth in total, rather it's intended to luxate the tooth. We will then take what we refer to as a tooth delivery instrument or a bird beak forceps, and I can simply remove this tooth atraumatically or minimally traumatically. What does that mean? The patient does not experience pressure because we're not squeezing the instrument. It takes a matter of seconds, and the comment that I get more often than anything is, "You're kidding. You're done. The tooth is out." That's not the experience people have with taking teeth out. We know taking teeth out is challenging. We know we break a lot of roots in the jaw. We won't go through all of that, but maintaining the socket, maintaining all 4 walls, allow me to prepare an osteotomy site for an implant, graft prior to placement of my implant, and do an immediate implant placement in this site. So I want to demonstrate this, and if you look at the the right side slide, I reflected the tissue. Now, in my techniques, and if you've heard me before, I am adamant that I do not make vertical incisions into mucosa. I know many of you have been trained to do papilla saving or whatever, but I strongly recommend that you do not make vertical incisions into mucosa. If you cut into mucosa, we will get prostaglandin and histamine release. The patient is going to hurt. They're going to hurt, and repositioning that reflection can be challenging, and we can end up with some scarring in those vertical lines. So here I demonstrate what I refer to as an envelope reflection. All I want to do is see that facial plate. Doctors, my failures in implant dentistry, Lauren, actually it's over 20,000 now that we placed 20,000 this past summer, I placed the implant too far facial. And we've all seen it, regardless of your experience. We've seen threads in the anterior, we've seen the grayness in the anteriors. So we must have 1 millimeter to 2 millimeters of facial plate of bone in all our implants for success. So I've learned through experience that if I do this envelope reflection, I can see the facial plate. I know it's intact, and I know that I'm going to get the result that is intended. I'm not going to go through the system that I use. Many of us use different systems, but they all are basically the same. We start with a small pilot drill. We go to a wider drill, wider drill. This is a tapered implant. And you can see the position of my pilot drill is not in the socket. I don't want to put it in the socket. Rather, I'm positioning it about 3 millimeters palatal to the facial aspect of the adjacent teeth. I'm kind of riding that palatal bone, and I'm engaging beyond the apex. The initial stability with any implant today is in the apical 2 millimeters. So even though our socket is shaped like an egg and our implant is round or tapered, we're going to fill that void with a graft material, but our initial stability is in the apical 2 millimeters, and we're positioned 3 millimeters palatal to the facial aspect of the adjacent teeth. We're going to simply widen the osteotomy and widen the osteotomy. And before I place my implant, I am taking our osteogen plug, our calcium apatite in a bovine Achilles tendon matrix. I can cut it. It has some kind of substance, a little substance to it, and I will pack it into the socket firmly, it's not amalgam, but firmly to the crest or slightly above the crest. I can then simply thread my implant directly through that graft material. It will allow me to thread through it, and what happens is the graft material is actually pushed to fill that socket completely, almost like caulking. And you saw what I did. I took a tooth out, and for those of you who have implant experience, I was able to torque that implant, getting my initial stability in apical 2 millimeters to 35 Newton centimeters. That's significant since the socket site is actually bigger than the implant itself. In an immediate extraction site, our implant is always placed 1 millimeter subcrestal, 1 millimeter into the socket, okay? Physiologically, we have to expect some bone loss due to trauma. If it is a non-extracted site, our implants are placed to the crest, or most implant systems are placed to the crest. Now, suturing is very important here. And now we did not use allograft and a membrane, but let's assume that I did, okay? If we had an allograft and we put a membrane and I made that envelope reflection onto the facial, I could clearly see a membrane being placed at least 2 millimeters beyond the defect. And I can fold it over so that it's passively underneath the palatal tissue. Most of us were trained to suture with our reverse cutting needles from facial to palatal. Makes sense, facial to palatal. The problem with that, and the problem some of us have had, including myself, doing that, is if we had a membrane, we would suture into the membrane. Patient comes back in a week or so to remove the sutures, or your team removes the sutures, and they pull the membrane out because the suture went through the membrane. The case becomes unpredictable. That membrane must remain intact for at least 6 weeks. So the technique that I use routinely, that I teach, is if I take my reverse cutting needle and simply go from the crest towards the facial, and then turn that needle around and go from the crest or the socket site to the palatal, I can then tie my interrupted suture and suture over the top of the membrane, because I can see this reverse cutting needle actually sliding over the top of the membrane. Now, in this situation, I didn't have a membrane, but always take a radiograph to demonstrate the position. We did not damage the interseptal bone. There really wasn't a lot of interseptal bone. The implant is placed 1 millimeter subcrestal, and we're trying to maximize the aesthetic to the best of our ability. Here I had a flipper made. The implant was buried underneath the tissue with a cover screw, and the patient did okay. You know, it's a flipper, it's removable, nobody likes it, but adapted to it. And you can see 4 months post-op, how the tissue healed. We have the same amount of interdental papilla on the mesial that we started with, because we never damaged that interseptal bone because we used the physics forceps, but we never had interdental papilla on the distal aspect. So we are compromised to some degree there. Here we uncovered, we scanned, we did a digital scan, and we fabricated a zirconia crown. Here's a healing abutment to allow the tissue to heal. We must have at least a 2mm band of attached gingiva on the facial aspect of all our implants to maximize the aesthetics. So doctors, a friend of mine took this picture up in northern Michigan of the moon with his telescope, and it's very important that you focus on the details. My protocols that we're demonstrating today are very predictable. They're very efficient. I don't have a myriad of materials. I have the membrane, our resorbable membranes. I don't even have a non-resorbable. I use Vicryl sutures, PGA, polyglycolic acid sutures. That's my go-to. They resorb to water. I like to see my patients in a week to remove sutures. I just follow rules that we demonstrated. So let's go to the posterior maxilla. We have a tooth that is grossly decayed. How are you removing this tooth in your office now? I'm going rhetorical question again because you can't answer me, but I'm assuming that many of us were trained to section this tooth. Section the palatal root from the mesial buccal, mesiofacial and distal facial, and take it out as 3 roots. If we try to take a forceps to it, oftentimes we will break a root tip, and we take 20 minutes or so sweating profusely, and end up leaving a root tip in the jaw, which is very, very frustrating to me. So I use the physics forceps, and even though these roots are very divergent, I was able to remove the tooth in a matter of seconds using the physics forceps without a lot of pressure. Here is another osteogen plug, and I got a little fancy here. I can cut it with scissors, mimicking the shape of the sockets. I'm placing it firmly into the socket, compressing it. It's not amalgam, compressing it firmly to the crest or slightly above the crest. And it will heal over time. Remember, integration occurs from the apex towards the crest. We have more radiolucency on the coronal portion, but certainly after a 3 or 4 month period, depending on the size of the socket, I feel very comfortable placing an implant into that site. Let's move to the mandible. Here we have a tooth, again, that is deemed non-restorable. I'll tell you, and probably many of you agree with me, my lectures around the country, I asked this question. I have never in my entire career seen so many root canal treated teeth fracture or break. I don't know if it's stress or whatever, but we are seeing a lot of fracturing of root canal treated teeth in the mouth. One actually happened to me. But this tooth is definitely non-restorable. So we have to decide how we're going to remove this tooth. There was some infection. So again, I took the physics forceps without a lot of pressure. We're not squeezing the instrument, simply rotating our wrist, placing the shovel-shaped part on the lingual aspect of the tooth, 1 to 3 millimeters subgingival, placing the bumper, which is acting as a fulcrum as far down the vestibule as possible. In a matter of seconds, I will remove that tooth. Curette, eliminate any granulation. And here you see we cut a piece of osteogen material and fill the 2 sockets to the crest or slightly above the crest. And here I didn't suture. Here I used periacryl or surgical super glue to close the site. Right over the top of it. It dries almost instantaneously. So immediately after extraction, and then the healing occurred over about a 3-month period where we see some changes. I'm sorry, let me go back to that because that's not really true. We took the tooth out, we took a radiograph, and we grafted, and you can see we still have radiolucency in that socket site. 1 week post-op, this is what the site looks like. Remember, epithelium physiologically is going to grow a 0.5 millimeter to 1 millimeter a day. So I don't expect primary closure. I will tell the patient, oh, you look really, really good. You're about 80% healed. Stay away from crunchy foods like nacho chips, potato chips, peanuts, popcorn, things like that for another week. After 3 months, we are looking at the surgical site, and all of you are capable of doing this with proper training. I know GoldenDent has some excellent implant training programs in the Detroit area, and they treat you very finely. It's very important that we evaluate the band of attached gingiva on the facial aspect of our implant. That is why I don't want primary closure with our socket sites. To get primary closure, I would have to pull the mucosa towards the center of the ridge, and that would inhibit attached gingiva on the facial aspect of our implants. So physiologically, the tissue is going to heal. Here I've taken an Orban knife, and I'm going to reflect this site to demonstrate to you what it looks like underneath. And it's not mature. It takes about a year for bone to mature, but we certainly have a site that we can predictably place an implant. I made that envelope reflection, no vertical incisions. And then I will go through the implant process. This is not an implant training program, but we take a pilot drill. We're kicking a field goal. We're placing the implant ideally mesial distally and buccal lingually along the central groove area of the adjacent teeth. We use the apices of the adjacent teeth as a guide. Remember, we get our initial stability with any implant system in the apical 2 millimeters. We're going to widen the osteotomy, take our measurements, just look at these sites. It's nearly impossible to make a mistake. Doesn't mean you can't abort a case, but you certainly, all of you have the ability to do these predictably with a little bit of proper education and maybe a little hands-on experience. So again, you're concerned about the mandibular canal, mandibular nerve. So we're using the apices, the adjacent teeth, as our guide, and don't go any longer than that. And that's a really good safety design. We're going to widen the osteotomy, harvesting the available bone, and then widening the osteotomy and placing our implant into the surgical site. And we are going to torque it to the crest. This is a edentulous spot, so we're going to put it to the crest. In an immediate extraction site, we're going to go 1 millimeter subcrestal. And we're able to torque it to 45 Newton centimeters. And when we're able to do that, we can then do what's called a one-stage surgical procedure. If I'm able to achieve at least 25 Newton centimeters of torque and feel comfortable, I can do a one-stage surgical procedure, meaning I can put a taller healing abutment, which will penetrate through the soft tissue, which eliminates the need for anesthesia and uncovering at a future date. And I'll congratulate the patients on how well they healed and tell them no more shots after today. So we torque that to 25 Newton centimeters. The healing abutment is slightly above the crest. And we put 2 interrupted sutures. We have a band of attached gingiva. We have an ideal situation for a future implant restoration. Postoperative, preoperative and postoperative CBCT analysis illustrates that even though the bone is not completely mature, we can visualize the vital anatomy, and we're able to place our implant into viable bone very predictably after a quick 3 months of healing following an extraction. 3 months later, we're going to remove the healing abutment. We scan, and you can now mill in your practice the final restoration. And the tissue, this is what I expect in all my tissue situations, and you'll get the same results. It's like a typodont, periodontal health. And because of the grafting material, here we did a screw retained implant prosthesis and provided the patient form and function in this situation. What about a situation like this, where we have a horizontal fracture at the post line, and we have a significant periodontal defect? We're going to evaluate. Here I'm using the physics forceps. I'm not wanting to disturb any interdental papilla, which is supported by the interseptal bone. We don't have a lot of interseptal bone here, but we're going to extract this tooth. We have some mesial interseptal bone, but no distal interseptal bone. So our final restoration, I know, is going to be compromised. Patient has some other crowns there, and we're not going to replace, but it's very important you communicate to your patients ahead of time on what you're able to achieve. But you can clearly see in my curetting that I have no facial wall here. So I'm going to make my envelope reflection, no vertical incisions, exposing the facial defect beyond the defect, beyond the defect. I'm going to use an allograft here, and I need to protect that allograft from invagination of epithelium. So I will use a resorbable membrane that will be passively placed, but I need to make sure that that membrane is placed at least 2 millimeters beyond the defect. Doctors, I know that's not what we do. We have a tendency to lay it on top, to tuck, rip, tear, suture over the top of it. And if that membrane comes out before 6 weeks, I can't tell you if the case is going to turn over or if it's going to be predictable. I want you to have predictability. We're going to go through the osteotomy as I demonstrated in that first case, anterior case that we did. We are not placing the implant into the socket site because there's no facial wall. Rather, I'm 3 millimeters palatal to the facial aspect of our adjacent teeth, riding the palatal wall, and I'm going to get my initial stability from the apical 2 millimeters. I'm going to widen the osteotomy, and I'm placing the implant, and this is a very important photograph. There's no facial wall on this implant. So I will put a cover screw. I'm going to bury it. I took my resorbable membrane, and I kind of rounded the corners, kind of reshaped it, and this is going to become my new wall. I passively placed it beyond the defect, and this is my new wall. I'm then going to take my allograft wetted with sterile water, sterile saline, fill that facial wall, passively place that membrane onto the palatal, and suture as I demonstrated earlier, from crest to facial, from crest to palatal. The implant is placed 1 millimeter subcrestal. You can see how the defect is repaired with our graft. There's still some radiolucency there, but look what happens after 3 months. We can make our impression here. I did a zirconia abutment with margins at or slightly subgingival, torqued it into position, and fabricated a zirconia crown. Now, I know this is may not be Academy of Cosmetic Dentistry, but we restored the tooth to the acceptability of the patient. The patient has a lot of other issues in their mouth, but we have a tooth that looks like a tooth, that feels like a tooth, and you're able to do this predictably, doctor, by following the rules. Again, taking a tooth, we see this all the time. Broken teeth, I'm going to use my physics forceps. I'm going a little quicker here. Removing the tooth atraumatically, filling that socket with our osteogen material, threading the implant directly into the material, burying it 1 millimeter subcrestal, and allowing it to heal. We have a tooth, again, that is deemed non-restorable. And how do many of you remove crowns today? I'm going to make an assumption that many of you would cut this crown out by taking a burr, high speed, make a slice onto the facial, onto the occlusal, onto the lingual, takes some type of separating instrument, and usually the mesial comes off, the distal stays on, and we play with it. This is called a WAM key technique, W-A-M-K-E-Y from GoldenDent. And I will simply make a little window, a little elliptical window in the apical third through the metal or through the crown, especially if it's a zirconia crown. You know how hard those are to cut. You go through a lot of burrs. And then I will simply take one of these special keys. There's 3 instruments, the very high quality stainless steel with a little ball in the end. And I can remove the tooth in a matter of seconds, literally. So you may want to look into that also. Now, this tooth we're extracting, but if you weren't, let's say we were just replacing a crown, you could use this crown as a temporary, or your staff could use it as a temporary if you were going to restore it. The roots are divergent, root canal treated tooth, so I'm sectioning it with a 557 surgical burr, taking the 2 roots out individually. You can see the curvature of those roots using the physics forceps. And you can see I'm only putting thumb pressure on it. The patient really doesn't experience any pressure there. Removing the 2 roots, take a radiograph, evaluate, curette, and here I grafted. To the site, immediately, there's still radiolucency there. We suture. I do not have primary closure, although it looks like I did. We do have some mucosa on the facial aspect. I'm just going to let this heal for about 3 months. After 3 months, I did a CBCT analysis to visualize, is this a case that we can place an implant? Is it healed well enough? And remember, our initial stability is in the apical 2 millimeters. 3 months post-op, and I'm going to run through this a little quicker, but you can see how things heal miraculously. I'm infiltrating with Septicane into the vestibule. We do not block implants, and I'm seeing the mucogingival line bubble up. The reason I do this is I want to see where that mucogingival line is, because I need to make sure that I have at least 2 millimeters of attached gingiva on the facial aspect of my implant. Oops, sorry, I didn't mean to do that. And I'll run through this a little quicker. So we're injecting, walking up the ridge, just blanching the tissue. Bone is not innervated at this juncture. We just want to numb the soft tissue. I'm taking my Orban knife, respecting the band of attached gingiva, and this is what I really want to show you. I'm reflecting my envelope, and what do we see there, doctors? We see viable bone. In 3 months, routinely. I'm not going to go through this process of the drilling because I think you understand it, but the bone quality was outstanding. Here we're going to place our implant into that socket site, and we are able to torque it miraculously and do a 1-stage surgical procedure. 1 week post-op, it's going to heal. After 3 months of integration, we remove the healing abutment. You can see the nice tissue cuff. We scan and we mill either in the office or the laboratory. We did a nice screw retained implant prosthesis, giving the patient form and function. Lauren, it's 10:02, and so if we have time for questions, I'll stop here, and you'll invite me back so we can finish the lecture. Are you there?
This is what happens when you don't unclick the mute button.
Okay. Are you a novice at this or what, you know?
Sorry about that. We're going to turn things over to Kurt in a second. As I know some of you may have popped on a little bit late here. As a reminder, the webinar was recorded, and that recording should go out sometime the next day or two. And the CE certificates, there's nothing you need to do. There's no quiz or test, anything like that. We know when you logged in, when you logged out. We will just go ahead and send you out the CE. That often is done by Friday, but it may be sometime until next week. But we'll stay on top of it. And if you don't have it by within a week or so, feel free to reach out to me. Tim, are you ready for me to put it over to Kurt?
Sure, yeah.
Okay, so as I mentioned at the beginning, we don't do these webinars without sponsorship and partnerships. I have been thrilled to work with Kurt Lawler at GoldenDent for well over a decade. They're the ones that bring in these speakers, and they always have special offers to make to everybody. So I'm going to turn it over to Kurt for now, and then we do see a bunch of questions, and we're going to get to the questions as soon as Kurt has made his special offer. So go for it.
Thanks, Lauren. I appreciate it. Thanks, Tim. I'm going to get through this quickly here to save time for questions. I'm just going to cover two things. As you know, if you join our webinars on a regular basis, we usually provide a promotional code if there was anything that sparked your interest on the webinar, or if you just wanted to stock up on some products to use on a regular basis. If you're already an existing customer, we value your time and we give you a code for joining the webinar. And then two, just because I have you here, we get a lot of customers that join on a regular basis. I want to quickly go through just some new products. Might not even be relevant to what we discussed this evening, but I just quickly want to mention them just because I have your attention this evening. So the code is going to be SMILE15. So that's just SMILE15. That's a 15% discount code is what we're doing this evening. For our regular customers, it's the same website, same deal. You can call or go to golden-dent.com. There's a little hyphen in there, and you can use that promotional code SMILE15 to save 15% on anything on the site. I'll mention a couple of things. So this is a kit that we've had for quite a while. Dr. Kosinski was always, I really believed, having a graft kit that's together, organized, ready to go, just the basics on what you need for your grafting procedures. This comes in a cassette. It's got your 10 basic instruments that you'll need for grafting. It's always ready and available. Nice kit, inexpensive. It's around $500 with the discount. So if you don't have the right grafting instruments, it's something to take a look at. And what it has too is the serrated curette, which is great for the granulation tissue that was covered this evening. When you're cleaning out the extraction site, it's important to have proper bleeding for use with these osteogen plugs, and these serrations that you'll see here on the serrated curette are perfect for that. Now, if in some cases too, if you can't manually get the granulation tissue out, this is a kit we have that's maybe for more some advanced type grafting cases, but there's some excellent tissue and degranulation burrs that are in there if you want to use a non-manual way to do that, or to clean the socket site out. Those two burrs there on the top are really excellent. And then the other ones, we didn't get into these advanced cases this evening, but these are more for like bone leveling and shaping and things like that we cover in our classes. So the plug, we went over that in detail. The large size is the most popular. If you're not using the product now, I would recommend the size large. You can always cut it to shape and make a slim out of it. So the large is probably going to be what I would recommend if you're not using the product. They come in a 5-pack or a 10-pack. The 5-pack is always a great way to get started. There's a long expiration dates, like three to 5+ years on the product. So everybody has an allograft. We try to keep our prices fair. We've had this allograft for quite some time. The feedback on it's always been great. It's obviously from a reputable tissue source or tissue bank here in the U.S. And if you're looking for a new allograft or just want to have some different sizes, this is one that we've used for many years, and the one that Dr. Kosinski likes in his office. So the two on the left are probably our most popular membranes, the EpiGuide or the Cytoflex Resorb. The CollaGuide and the other one from Implident, the handling on those can be a little bit more challenging. They're all long-lasting resorbable membranes, so you don't have to worry about going back in and removing the membranes. This is what we recommend would be the two on the left if you're looking for a membrane that's going to work for all of your cases when you need a membrane. PGA sutures on top. These are really affordable. Look at your pricing on your PGA sutures. We spent a lot of time sourcing these, testing them. They're very good and they're a reasonable price. And then we obviously have the chromic gut and silk, but the ones that are the most popular are going to be your PGA. Physics forceps, we went over this in detail. This was our very first product back in 2007. Still a great product. We went over that. More than happy to answer any questions if anyone has some questions on those this evening. We also have obviously the conventional instruments, 150, 151, luxators, periotomes. There's lots of ways to extract a tooth, and we try to teach and cater to each different way that makes sense for the practitioner. So quickly, what's new? We're really happy about this. The X-Star woodpecker curing light, these curing lights have come a long ways. We say half the price of market leaders, and people will say, well, yeah, is the quality the same? And it is. And we recently had some studies completed by Dr. Richard Price, who's well-respected opinion leader or valuable source on curing lights. And if you look at the results, and we're happy to share the results if you want to see the actual study from Dr. Price. But this new X-Star curing light and some of the lights that are being made now by Woodpecker, they are of equal quality to the top brands on the market. And the pricing is very, very competitive. So it's something to take a look at. You know, don't write off the woodpecker brands as something being, you know, a cheap curing light you keep maybe in your laboratory. That's just not the case anymore. And we've proven it through the studies. One other item here is if anybody's currently using like Isolite or Dry Shield, or you're looking for adapters or maybe an autoclavable Isolite mouthpieces, which you know, aren't available, or a single-use Dry Shield, or maybe just a better lightweight tubing. If you're already using this product in your office, we have all these parts and pieces. We just picked this up and we're happy to have it. The feedback's been great. Their adapters are excellent. The mouthpieces have a little bit of a what we consider to be a little better design and function, how they perform, and it's something to take a look at. If you're not using the system at all, or you're just frustrated with what you're using for isolation, there's also a great intro pack that we have on the website that you can take a look at. There's a lot to talk about with this product, and I don't have time this evening, but I just wanted to mention we now have this if you haven't seen it. The only thing I'll mention here is in the corner. A lot of dental offices have been kind of looking for like a wizard style type wedge. We do have that available, the 3 wedge from Polydentia. We've had great feedback on that. So if anybody's still searching for their favorite wood type wedge that they've been having some trouble sourcing, I'll just mention we do have that, as long as some other excellent matrix products, which I'm just going to kind of skip over this evening because we you know, short on time. Lastly, the digital sensors. We have these, and you know, we wanted to make sure that before we offered X-ray sensors or any of this digital type of equipment, that we had excellent support. Dr. Levine and his digital dentist team provide the support for us. So if you buy any of these products from us, and that's exclusive to us, we cover the expense and the support to get them integrated with your practice software, and to ensure a smooth transition. So I just wanted to mention that since we're doing a webinar with Dr. Levine this evening. And then lastly, if anybody wants to do this type of cases that was shown this evening by Dr. Kosinski, we've been doing live patient classes in Detroit for, gosh, I don't know, since 2010, I think. They're live patients, so we'll see 65 up to 100 patients, just depending on how many doctors we have. We try to keep it to around 15, 20 max doctors, and it's live patients. So day 1 is a lecture, and then day 2, you're working on patients all day. So you're extracting the teeth, you're grafting, you're suturing, you're placing membranes. These are 2 excellent classes to get involved in grafting, or if you maybe aren't seeing predictable results and you want to do the cases yourself, this is a great opportunity. There's no licensing restrictions. It's a teaching facility. You don't have to have a Michigan license. You can learn more about this. I didn't put it on the website, but it's there's a link on golden-dent.com, but the website's amplifydental.com. That's it. Sorry, I just wanted to get through a couple things. And so SMILE15 is the promotional code. I'll leave that up, and I'll turn it back to Lauren and Dr. Kosinski for the questions, please.
Thank you, Kurt. Tim, we got a lot of questions. You ready to roll?
Always ready to roll.
Okay, let's try to get to as many of these as we can. Can lasers be used to decontaminate an infected surgical socket once the tooth is removed? Is there any chance of causing necrosis if you use a laser?
Yeah, I do. I use a diode laser a lot to decontaminate the site. So yes, especially in those sites. You know, oftentimes the question is, I'm worried about the floor of the sinus, or I'm worried about, or I have a dehiscence through the bone. I will use my diode laser to sterilize the site prior to grafting. Absolutely, good question.
Okay. There are some concerns, I guess, some people out there about resorbable collagen membranes, that they're not strong enough, that you know, they can't stand the saliva, they resorb quickly, they can cause the graft to come out prematurely. Has that been your experience or not at all?
When you use a high quality material, and again, what we're using is a 3 to 4 month, and I need the membrane to remain intact for 6 weeks. So when you're using a high quality product, like one of the ones that Kurt mentioned earlier, that is not an issue. There's so many materials out there, and I don't like to get bogged down because I don't use those materials. I keep my inventory my number of products very small, because after 40 years, we've kind of perfected what we did.
Okay. Just as a follow-up to that laser question, is there a specific setting that you use when you're debriding?
We use the NV Pro diode laser, and it's the there's presets in it. I'm sorry, I don't know exactly. I think it's a the laser is a 960 diode laser.
Okay. I know it's probably hard to say because it depends on the patient, but if you don't graft, how long should you expect that ridge to be preserved if you're not putting an implant in as well?
Yeah, we say that you have about a year, and when bone is not stimulated, it will resorb, and you can imagine how many cases every dentist out there, regardless of their experience or their years in practice, you see that horse's saddle look, or you see that concavity on the facial aspect, which makes even our conventional dentistry challenging. So educating your patients on why it's important that we put something in that socket to minimize bone loss, I think, is imperative in today's environment.
Okay. I guess it maybe is a question more for Kurt. Are most of these products available in Canada, or some, or none, all?
Yeah, I mean, we do ship to Canada pretty much every day. So whether there's a specific dealer in Canada, I'm not sure, but I know we do ship from Detroit to Canada pretty much every day.
Yeah, I mean, especially if they're in Ontario, you can drive over to Windsor and just give them a box and they can take it home. It's easy. Okay, back to Tim. Instead of allograft with membrane, can we use osteogen to substitute for the allograft? And lastly, how can we build bone vertically with the membrane? Does it take the epithelium too long to migrate over the membrane to be successful?
So, that's a great question. And, we have a lot of experience, and we use a lot of different techniques and products. And in this lecture, what I wanted to demonstrate is when we have a socket with all the walls intact, we can grow that socket, we can grow bone and prevent vertical bone loss. If the defect is greater than 5 millimeters, I will use, to this day, allograft and a resorbable membrane. If it's less than 5 millimeters, I have no problem using osteogen. You don't necessarily need a membrane with osteogen, but when you have a facial defect, depending on how large it is, the bone regeneration facially is different than apically and occlusally. Remember, I said bone integrates from the apex towards the crest. So I would rather have belts and suspenders if you're going to do that, but that's not really what I wanted to demonstrate today. I wanted to give you a concept of predictability in these initiating cases. Getting
Okay.
vertical height is very, very challenging, but I have no problem. Epithelium grows very, very fast. I like to see my patients in a week. I'm more concerned with a band of attached gingiva on the facial aspect than leaving the membrane exposed, because epithelium will grow over the top of it.
Okay. This one's for me about the webinar being recorded. And the answer is yes, the webinar has been recorded. Typically, GoldenDent will get that out within a day or two. And as a reminder, for the CE, there's nothing that any of you need to do. We track when you logged in, when you logged out. As long as you were here for most of the webinar, I think it's like 65, 70%. So, at least 45 minutes or so, you will be sent that CE certificate. Those may start appearing as early as Friday. Oftentimes, it may be a little bit into next week as well. Another question for you, Tim. On the case that you showed, I think it was the first case with number 21. Why not use a bayonet forceps and do rotation movement as it's a conical root?
I don't know. If it works, great. We all have our favorites.
Whatever
and
works in your hands. Yep.
yeah, and it's just so predictable. Taking teeth out is just a predictable matter of seconds, with no stress or strain on my body. There's 100 ways of taking teeth out. A lot of them don't work really well because I see a lot of root tips left in the jaw, Lauren. That it's frustrating.
Well, that never happened to me as when I was doing perio full time. Usually because they had about a 10 millimeter pocket and tooth was flapping in the breeze. It was kind of hard to leave a root tip, but I managed to from time to time. For the case that you showed with tooth number 9, could you have done an immediate temporary implant crown versus a flipper?
That's a great question, and I lecture all around the country, and I always say this right up front: I am not an immediate load person. Other than full arch cases where we have an arch, and the reason is because I've lost a lot of cases, and they can't function. Number one, we have to get at least 35 Newton centimeters of torque, and in a socket site that can be challenging. Number two, there can't be any pressure whatsoever. So the patient is instructed that they have a liquid diet and they can't eat anything that they can't smash with a fork. So the thought process is, well, let's just take it out of occlusion. Well, that's fine unless they forget. They're on an airplane and they bite into a biscotti and they go, ouch, they're probably going to lose that implant. So that's just me, through experience. I don't like failure. I don't like issues. So personally, I'm just not an immediate load person. I've seen hundreds of doctors do it, and I have no issues with it. The literature is clear on it, but I've seen a lot of problems also.
Okay. If you're using a plug graft in a site that has a missing buccal plate with no membrane, is that going to decrease your chances of success?
Yes. Yeah. Again, the third time, the rules are all the walls intact. I'll use the Osteogen plug. 5 millimeter or less facial defect, I can still use an Osteogen plug with or without a membrane. Greater than 5 millimeters, I personally will use an allograft and a membrane.
Okay. Well, if someone's using the plugs and the patients are basically showing more problems with postoperative pain and swelling versus particulate grafts, is that a technique issue, or is that something you've ever experienced in your practice?
That's a great question. That's a really relevant question. Discomfort comes not from the graft material. It's the incision process, and many of us were trained to make vertical incisions in the mucosa. And if you slice into mucosa, you will get prostaglandin histamine release, and the patients are going to experience pain, swelling, bruising much more often than if you don't incise into mucosa. So the material is packed firmly. It's not amalgam, but no, I don't see any difference. The results are exactly the same in a very short 3 or 4 month period of time.
Okay. What about if there is an abscess after you remove the tooth? Are you still going to graft? Or are you going to consider an immediate implant possibly in that situation?
As I said, if there's an infection, number one, you have to eliminate the granulation. Curette. Kurt talked about his kit with the serrated edges on the curette. You want to remove the granulation. You can use a diode laser to sterilize the site. I will graft an infected site after cleaning it out, but I will never immediately place an implant in a infected site following grafting. That's just my rule of thumb.
Okay. This is kind of related to the previous question about the plug and the missing buccal plate. Do you always place membranes with no facial bone, or sometimes you just do an Osteogen plug since you don't need a membrane with that? Would it not be as predictable?
No, the facial bone is different than a vertical bone. The physiology and the healing is different. So yes, I would use a membrane on the facial plate.
Okay. Are you typically using just the physics forceps, or are there some circumstances where you may need to use a conventional elevator as well?
There's always exceptions to the rules. Rarely do I use anything other than the physics forceps, rarely. I do have periotomes from GoldenDent. You know, we have luxators in the office. You know, you do everything you can to get a tooth out, but if I can get a purchase point on the palatal lingual aspect of a tooth, physics forceps is my go-to. We've just been doing it for so long. I say it all the time. If you watch my videos on YouTube, we probably have 200 videos on Dr. Kosinski. You hear me say magic. It's magic sometimes. Yeah.
Yeah. Can you, I can't remember if you mentioned it specifically, the name of the bone that you're using for grafting into sockets when the tooth's been removed, and the name of the membrane that you use. Is there like a go-to membrane, a resorbable membrane that you like to use?
The GoldenDent materials. They're 250 to 1,000 microns allograft, and they're resorbable membrane.
Yeah. Okay. Does it make sense to combine bone particulate graft material along with an osteogen plug?
Sometimes I'll layer. You know, I like the like if I'm doing a sinus elevation, or a Caldwell lock, or a very big defect, I will place an osteogen plug because of its consistency, and I will layer it with allograft. But remember, if you're using allograft, you must protect it from invagination of epithelium with a membrane.
Right. Are we almost done with the questions? I'm not sure if you know this off the top of your head. The CDT codes that you use for your grafting procedures?
No, you can ask. You know what? You know what? I should actually put that in the lecture at some point. I don't. I know that dental insurance doesn't cover grafting for general dentists very often, but I do understand that there are some that are giving some coverage to it. Kurt, maybe you have that information. Do you have the codes?
You know, I do. Not right in front of me right this second, but yeah, maybe I do. So whoever's asking, I guess, if anybody's interested, just email us and we can send you we have a sheet that we always put in the or like a slide we always put in the presentations for the classes. So I'm happy to share it if I don't have it right in front of me that I can share it. So, but I can if anybody asks.
Yeah, when I send you the report, Kurt, you'll be able to see who asked the question and be able to get them that information as well.
Okay, perfect. Thanks.
This is shocking. I think we're out of questions.
Okay.
Tim, yeah, wow. Now, hopefully your Tigers are winning. I don't know. My Blue Jays are certainly up, but that's all that really matters to me. But anything you'd like to say before we call it a night?
Oh, Lauren, I always appreciate these. I hope it was helpful to our. We had a big group today, and hopefully everybody appreciates it. I hope everybody stays safe and healthy and has a great fall with school starting again. And just take care and be strong and healthy and be financially successful. Have a great night.
Well, thank you as always, Tim. As I mentioned at the top, when Tim Kosinski is speaking, you know, it's like that old commercial when E.F. Hutton talks, people listen. We just get our best turnouts, usually double anything else that we're seeing. So thank you for always sharing your expertise. Your slides are always current and unique. And you know, that's why people always show up, because they're always going to see something new, and we really appreciate you for that. As I mentioned at the beginning, we don't do these webinars without GoldenDent. I've worked with Kurt and his team for well over a decade. They're always bringing in amazing speakers, always great content, always great specials. You see the 15% Smile 15 code there, and I would highly encourage people to take advantage of that. They've got a great return policy, although we don't know anybody that's ever returned their stuff because it's really high quality stuff. But they're a really good company to work with. They stand by their products. And we do these on a regular basis. I think we have one, Kurt, I think, is it November? Did we have one before November? I can't remember. I think we have one in November and December.
Yeah, November 4th is on, we have one on Endo, and I meant to actually add that to the slides, but I'll put the, in the follow-up email with the replay, I'll put a link in there if anybody wants to register early while you're thinking about it, but it's November 4th is our next webinar.
Great. And as I said, we do them on a regular basis, and we thank Kurt and Jason and Jackie and everyone over at GoldenDent for continuing to support these educational experiences. And we thank all of you. We know that your time is valuable. I'm going to keep doing this as long as people show up. And when we have 850 that register, they're showing up. So we hopefully we find great topics that interest you. You're always free to shoot me an email if you have other topics you'd like to see in future webinars. I'm happy to consider anything that people want to hear about. Please stay safe and healthy out there. Thank you again all. Final reminder, the recording should go out in a few days. The CE anywhere from about 3 to 7 days, so keep an eye on your inbox for that. Nothing you need to do, no test, no quiz, nothing you need to fill out. Once you logged out, I'll send a report to Kurt, as well as the recording, and he'll get that off. So we look forward to seeing all of you on our next webinar. Good night, everyone.
Good night.